Good afternoon, everyone, and welcome to the final 2020 Research in Focus discussion. I'm Christy Stathis, the Children's Research Fund Chair. It's nice to have so many of our volunteer board members with us today, along with many guests. For nearly 70 years, research education has been at the center of the Children's Research Fund mission. In collaboration with our partners at the Anne and Robert H. Lurie Children's Hospital, the Stanley Manne Children's Research Institute, and the newly announced Patrick M. Magoon Institute for Healthy Communities, we've designed this research series to help parents, guardians, and caregivers better support the health and well-being of all our kids. Now I'm happy to introduce you to my fellow board member, Kathy Graham. Kathy is the Children's Research Fund Committee Chair responsible for research education. Kathy?
Thanks, Christy, and good afternoon, everyone. It's a true pleasure. I get to introduce Dr. Heard-Garris. She's a pediatrician and a physician investigator at the Anne and Robert Lurie Hospital of Chicago, and also in the Department of Pediatrics at Northwestern University Feinberg School of Medicine. She examines the influence of social adversities experienced in childhood and subsequent child and adolescent health. Dr. Heard-Garris is also interested in the factors that contribute to a child's ability to thrive, something we all want for our children, despite these experiences. In August of 2019, she received her Career Development Award, which is funded by the National Heart, Lung, and Blood Institute. And with this award, she plans to investigate adolescent cardiometabolic health. She believes in using research to better inform clinical practice and policy that supports children, their families, and their communities. She's an active member in the American Academy of Pediatrics, and serves as the chair and founding member of the section of Minority Health, Equity, and Inclusion. Dr. Heard-Garris completed a prestigious Robert Wood Johnson Foundation Clinical Scholars Fellowship, boy, that's a mouthful, at the University of Michigan. She earned her Master's of Science in Health and Healthcare Research. She received her Doctor of Medicine, or her MD, from Howard University College of Medicine, and helped to launch the student-run free clinic serving DC residents. Dr. Heard-Garris earned her Bachelor of Science in Biology at Spelman College in Atlanta. She has had numerous media appearances, including CNN, Sesame Street, NPR, NBC, and numerous others. And she's written many articles as well. Dr. Heard-Garris, her husband and 7-year-old son live in Chicago, and they're relatively new here, and they're beginning to better understand the phrase winter is coming. But at least you're not on the East Coast today. We're kind of getting a break today. So please go ahead.
All right, hopefully you guys can all hear me now. I am so excited to be here today and to talk to you about adversity in children and how we can support them and how we can make, hopefully, their communities better as well. Let's see if the slides will participate with me. So as you leave today, if you don't remember anything else, I want you to know that adversities in childhood translate into poor heart and cardiometabolic health in adulthood. However, positive emotion might help to disrupt this trajectory for kids. Let's set the tone. 1 in 3. A Black boy born today has a 1 in 3 chance of going to prison in his lifetime. A Latino boy, a 1 in 6 chance, and a white boy, a 1 in 17 chance. Here's a great visual from the Prison Policy Initiative that shows on the left the makeup of white, Black, Latino, and Native populations in the US, and on the right is the representation of these same populations in the prison system. So on the left, you see 64% of the US population is white, and 39% of the correctional population is white. Whereas In the US, 13% of the population is Black, but represents 40% of the correctional population. And similarly, 16% of the US population are Latino or Latinx, and 19% are in the prison population. And for Native populations, 0.9% are in the US population and represent 1% of the correctional population. But what about in Illinois? Illinois has an incarceration rate of 564 per 100,000 people. And that includes prisons, jails, immigration detention centers, and juvenile justice facilities. But for African Americans, the reality is far worse. Here's another visual from the Prison Policy Initiative. And here you can see that white people in Illinois represent 64% of our15%, but in the correctional population represent 30%. Whereas Black individuals in Illinois represent about 15% of the population, but over half of the correctional population. So represented slightly a different way, this shows the number of people incarcerated per 100,000 people in that racial or ethnic group. So here you can see that Black people experience an incarceration rate of 2,128 per 100,000 people. Okay, but why? Why am I talking about this at a board meeting? These numbers are staggering, but what does this have to do with childhood adversity? This is what we've all come to talk about today. So, but let's set the scene so I can set this up for you. By the end of our discussion today, I expect that you'll be able to list 2 to 3 adverse childhood experiences, whether they're original or expanded ACEs, describe the relationship between ACEs and health, discuss how ACEs and racism intersect and influence health of children and adolescents, and discuss a potential intervention to foster resilience in individuals with ACEs. So we're going to set the stage by starting with some background information on ACEs. I'm really interested in social adversities, and a common framework to think about these adversities and organize our thoughts around it is called adverse childhood experiences, or ACEs. And these ACEs are important for health. So the original adverse childhood experiences, or ACEs study, was conducted between 1995 to 1997 and included 17,000 people that were getting checkups in Southern California. They were adults. And Dr. Vincent Folletti, the study's lead author, found that certain adverse experiences were common in adulthood, and common in childhood. And these experiences were categorized into 3 groups, which were abuse, neglect, and household dysfunction. And I don't really like the term household dysfunction. I like to say household circumstances. And within abuse, we have physical, emotional, and sexual abuse. We also have physical and emotional neglect. And then within household circumstances, we have people that live with household members that have mental illness or incarcerated relatives, living in a household where there's domestic violence or mothers treated violently, substance use or abuse, and divorce. So we took, and we're going to take, a deep dive in incarceration and about ACEs and incarceration and how that impacts health. But I want you to see it's not limited to incarceration. So having a history of divorce or having a history of living with someone who's had a mental illness or mental condition can also impact health. So how the ACEs are scored is they add each individual exposure that a person has together, and it gives them an ACE score. But the score doesn't take into account how many times something has happened to an individual. It's just whether it's happened or not. So yes or no. And as you can see, again, incarceration is on the list, but it is not the only thing there. The ACEs that were identified in the 1990s were not inclusive of the experiences of children from urban or also rural backgrounds or low income backgrounds. So in the 2000s, Dr. Roy Wade set to expand these original ACEs and be more inclusive of other experiences, adversities that children might encounter. There's been a recognition that economic hardship, the death of a parent, and racial discrimination can impact health. So Roy Wade expanded these ACEs and included discrimination, economic hardship, negative life events, parent psychopathology, bullying, which includes cyberbullying, and also community violence exposure. So these are the expanded ACEs. The original and expanded ACEs are thought together to impact health. So ACEs have an important influence on cardiometabolic health. And as you heard Kathy say, one of my funding streams is through the Heart, Lung, and Blood Institute. So we're particularly interested in how this impacts the heart health of individuals. So individuals that have ACEs or have been exposed to ACEs are 2 times as more likely to have heart disease. They are 2 times more likely to have severe obesity, and 1.5 times more likely to have diabetes. So those are the outcomes, but they also have behaviors that are more likely. They're 10 times more likely to use illicit injection drugs, 7 times more likely to struggle with alcoholism, and then twice as likely to have ischemic heart disease or stroke, and then 1.5 times more likely again to have diabetes or cancer. And so those outcomes are seen in adulthood, but kids don't wake up one day and are automatically adults. There is time in between childhood and adolescence where these exposures happen and give rise to these outcomes that we see in adulthood. So I want to talk to you about ACEs and racism. And one of the reasons why I focus on these together is because often we have a conversation about adverse childhood experiences without talking about the structures that give rise to these experiences. And so here, I really like this graphic because it embodies adversity as a tree. And so here you see that the soil that the tree is in is adverse collective historical experiences. And that is experiences that a group has together. So like slavery or genocide or mass incarceration, displacement, and the Holocaust are collective historical experiences. And then the tree's roots that are in that soil are adverse community environments. So that's racism and discrimination, community violence, lack of education or economic and housing opportunities. And so then those roots then give rise to what we are talking about, which are adverse childhood experiences, which we've gone over before. But I wanted you to see this tree because sometimes we're just talking about the leaves and the branches, but really we need to also think about the roots and the soil that gives rise to these adversities that we see in children and in their communities. So we're going to come back to where we started, which was incarceration. The incarceration of a parent, as you now know, is considered an original ACE. But I want you to understand that this specific ACE has a disproportionate effect on children and families of color. So that's how here ACEs and racism intersect. So I have a question for you. I know we're on Zoom, so don't shout it out. Just think about this. How many US children have had a parent incarcerated? And I should add that they lived with, because that's the numbers that we have. So I'll give you like a half a second. 5 million. 5 million children in the US have had a parent that has lived with them go to jail or prison. And this figure is the most updated figure we have, and it's from 2015. And we know it's an underestimate because the rates of incarceration are rising, and it doesn't take into account the number of children who have not lived with that parent that has gone to jail or prison. And the US has the highest incarceration rate in the world. And we know that Black and Hispanic children, rural children, and low-income children are disproportionately impacted by parent incarceration. Ooh. This is going really fast. Valerie, I think the timings are on this slideshow, so it's going really fast, and I wonder if we can slow it down a little bit. Sorry there. Giving away my punchline here. So one of my questions was, how does incarceration of a parent impact the health of children and adolescents as they grow up? And so there's a growing body of literature that indicates that parental incarceration is detrimental to the health of individuals, of their offspring. Specifically, oh, sorry, we went through this. Specifically, the prevalence of asthma, HIV/AIDS, and also depression, anxiety, and PTSD are higher among individuals that have had a parent incarcerated. So on this study, I found that young adults with a parent incarcerated during childhood were more likely to skip medical care, misuse or abuse prescription drugs, and have 10 or more lifetime sexual partners. And then following that study, I wanted to understand the influence of being directly impacted by incarceration, so you yourself within the carceral system, or having an indirect exposure, so having a parent incarcerated, and which was worse for health, and if they added up to have worse health outcomes. So this study, we looked at depression, anxiety. Valerie, I don't know if you can turn off the, I'm sorry, we're gonna have to pause this because it's going too fast. Valerie, if you can hear me, if you can turn off or deselect the timings, I think there's like some timings or something on this slideshow.
One moment, everybody.
Okay, thanks, sorry. I'm gonna keep talking and then hopefully we can get the slides in a way that you guys don't have to read so fast because I can't talk that fast. I'm a fast talker, but not that fast. So one of the studies that I looked at was trying to understand how do ACEs impact others and get more ACEs. So having a parent incarcerated influences the health of their children or their offspring. But being incarcerated yourself as a juvenile or as a teenager, how does that impact your health long term? And so for this particular study that I was hoping to talk to you about is we looked at mental health. We wanted to know depression, anxiety, suicidal thoughts, and mental health counseling for those that have had a parent incarcerated, those that have been incarcerated themselves, and those that have had both. And we actually found that those that had had a parent incarcerated or been involved themselves in the justice system were more likely to have depression. They were also more likely to have anxiety. And those that were had a parent incarcerated, so not themselves involved in the carceral system, were more likely to have suicidal thoughts. So, oh, perfect. I think you might have fixed it, Valerie. Yeah?
I hope so.
Thank you. Perfect. All right. So these were, I was going to show you the numbers behind it, but essentially having an incarceration exposure, whether it's yourself or whether it's a parent, so a remote exposure, is worse for your mental health. However, we found that those that had had incarceration exposure were actually more likely to have mental health counseling. I can't speak to the frequency or the quality of that mental health counseling, but they were more likely to receive it. Uh-oh. There we go. And that's just what we said. These are the scientific numbers behind it, but depression, anxiety, and PTSD were the biggest things that we found. And another really startling finding from this study is that we found that 1 in every 100 US children have had both exposures. So had a parent incarcerated, but also themselves have been involved in the justice system in some way. So in essence, ACEs begetting more ACEs. So finally, we're going to talk about interventions. We spent a really large chunk of time talking to you about ACEs and racism and the association with negative health outcomes. So if you're not depressed yet, I maybe didn't do my job, but now we're going to talk about resilience. This is a real big passion of mine, thinking about how do kids thrive despite having adverse childhood experiences. So why should we focus on resilience? I get this question a lot, partly because people are wondering, well, why don't we just remove the structures? I showed you the tree. Why don't we remove those structures that are causing adversity to kids and communities in the first place? And I'm a strong believer in doing those things. I think that is really of the utmost importance. But unfortunately, eliminating structural racism and eliminating the barriers won't happen right now overnight. And there are still kids and families that need help and that are in adverse circumstances right now. So how do we give them the tools and things that they need to overcome those circumstances? For me, resilience offers the promise of mitigating negative health trajectories for children that have ACEs. In one of my studies, we looked at what are the things that promote resilience in kids. And we found that on the family level, attending religious services together often, eating meals together, and sharing ideas, sharing things that matter, help to promote resilience in kids. And on the community level, we found that being in communities that had amenities, so libraries and parks and sidewalks and those that were clean, helped to promote resilience in kids, as well as being in a safe neighborhood or a cohesive neighborhood. So meaning in this neighborhood, we look out for each other, or in this neighborhood, people know who I am. Kids that lived in safe and cohesive neighborhoods were more likely to be seen as resilient. And then also having a mentor present. So not necessarily a person that was in the household, but somebody else that believed in the kid. These children were more likely to be seen as resilient. But unfortunately, as you all probably know, not all children have access to these resilience promoting factors. Not all children come from families that are able to sit down and eat meals together or live in communities that are safe and that have sidewalks and parks and opportunities. So that's where this intervention comes in that I'm really excited about sharing with you all. So we know that ACEs and stress increases your distress, your psychological distress. And we also know that ACEs are associated with severe obesity. And so those two things together produce higher inflammation and more likely to have poor cardiometabolic health, poor heart health. However, positive emotion might help to ameliorate or make better the risk of having poor heart health in adolescents and young adults. So my big questions, I alluded to them a little earlier, are what's happening in adolescence? Kids don't just all of a sudden overnight become adults. There's a process, and there might be critical windows, particularly in adolescence, that these changes are happening within their body after being exposed to adversities or while being exposed to adversities. And how can we harness positive emotion and then in the research that we know about positive emotion to help lessen that risk so that these kids don't grow up to have severe heart attacks and cancer and diabetes and strokes? What can we do? So my research with the lab really seeks to bridge that gap between what we know between ACEs and adults and to try to understand what's happening in adolescence and how to break that gap. So the study that I'm going to talk to you about is called ACHiP. It's ACEs and Cardiometabolic Health in Pediatrics. I'm really excited because we are going to be recruiting teenagers from 3 Lurie Children's Clinics. And we have a really ambitious goal to recruit 500 adolescents. And we are going to ask them to complete surveys for us. And that survey is going to tell us about their ACEs, and also they're going to tell us about their health behaviors. So Do they smoke? Do they vape? Do they, what health behaviors are they engaged in? And so that's all self-report. They're giving us that information. But the power of Lurie and being able to use patients that have gone to Lurie is we're able to pair it with their actual health record. So what actually is their heart rate? What actually is their BMI and their blood pressure? And trying to make those links between the social adversity and the health that we're seeing right now in adolescents. And, unfortunately, we're doing this study in the midst of a pandemic. And so we have to be really understanding that there's additional stressors placed on our teens. Right now, they're navigating the influence of COVID-19. So not just being ill or having COVID, but also the influence of e-learning and the influence of not seeing their friends and not having the events that they would have at school normally. In the same vein, we had a very tumultuous summer, and structural racism became on the forefront of our news in this country. And so how do experiences or exposure to structural racism or other episodes of racism impact the health of our children? So in 100 of the kids that we're going to recruit, we are going to look at inflammation. We're going to collect blood samples and also do their height and weight when we're able to safely, to understand more directly what is happening right now in this moment. So paired with those key data points, we are going to be adapting and developing an intervention that focuses on positive emotion for teenagers. And so you can think of this positive emotion intervention as a toolbox. And there are different tools that we're going to teach kids and expose kids to each week. So for example, savoring positive events and scheduling positive events. So scheduling good things for them, good things to happen to them. They are scheduling them. And then they will come back and tell us how it went. They'll get homework and say, hey, I tried that tool, it didn't really work, and so we're gonna be teaching them different ways to cope and hopefully adapt to the circumstances that are not ideal. And we're gonna study that. So I ultimately know, and now that adversities in childhood translate into poor cardiometabolic health in adulthood, not just incarceration, beyond incarceration, but potentially positive emotion might disrupt this negative health trajectory. And by investing in children and teens now, we could disrupt intergenerational cycle of adversity and trauma, reducing the burden of poor health and shaping the health of future children and teens. And so with that, I'd like to give my immense thanks to my research mentors. I have a phenomenal team of research mentors, including Dr. Davis, which I'm sure some of you know, or all of you know, Dr. Mercedes Carnathan, who is an epidemiologist and actually a leading thinker on COVID-19, Judy Moskowitz, who is a social psychologist, helping me to understand how to really implement this positive emotion intervention, and also Greg Miller, who's a psychologist that does a lot with biomarkers and heart health in teenagers. And a big thanks to my lab team, who I couldn't do this work without them. And I just would like to thank all of you for allowing me to share my passion and my research with you today. And I'm so excited to hear your questions.
Thank you so much, Dr. Heard-Garris. That was fascinating. Like I said in my opening comments, I think we all want to see children thrive, especially those who have a lot more challenges than others. We have a number of questions here. I'll start with one that came from one of the folks on the line. My college-age child recently pointed out that his cohort, the 2000 birth year, have seen many traumas, from 9/11 to the Gulf Wars to COVID. Please, how do you see this affecting these individuals long-term?
It's a really good question, and I don't know that I have a really satisfying answer for us right now. I think, unfortunately, time will tell, and we will see how the impact of those kind of more distant things like 9/11, but also like the Flint water crisis. There's so many things that have happened for this generation of kids, and frankly for us, that it's hard for me to say like this is what's going to happen. But I certainly am worried about the mental health and also the physical health of our teens and our adolescents right now as it stands and as they age, but also thinking about when they have children. So we've seen studies that have looked at kind of these historical traumas or historical adversities that a group experiences and how that is actually passed on to the next generation of kids that have yet to be born. So lower birth weights or being premature. And so those are very real consequences that might come through with this next generation. I hope that's not the case. You know, there are people that are really working to help bring resilience and bring in interventions that are helping to combat all of the stressors that kids have endured. But, you know, we will see.
And we just got a question on the chat that I'm going to read to you. How can you make some of these changes when proving a positive experience, providing a positive experience if a supportive environment is not available to the child?
So let me make sure I understand that. How can you provide a positive experience if all those kind of resilience factors aren't present for children?
Right, in the supportive environment, right.
Yeah, so one of the, so the study that I kind of talked about at the end about those resilience factors, one of the reasons why I was really interested in doing that study is because I wanted to focus on community factors, because it's hard, you know, as a pediatrician, I am so privileged. Like I get to see families and they tell me things and children tell me things that they haven't told their best friend. And so I'm able to act in a small way, but act at the family level and really try to help families, but it's not always possible. But what's really exciting to me is that on a community level, like libraries and parks and those things, like those are things that we can, you know, advocate and lobby for with respect to our community leaders and our local governments. Like how can we make communities that best support children? And so those are one of the things that I think about, but also there are already existing community organizations like Big Brothers, Big Sisters, and mentorship groups that have been longstanding and new ones that are coming up. So I think it's on providers and people who work with kids to kind of keep their finger on the pulse. If that's not happening at home, how can we make sure that environment is present at school? Or how can we make sure that environment's present within community? And if not, what do we do? How do we help these kids? It's a great question.
So tell me about, you know, you're doing all this great research, you know, in this study, gathering data from 500 adolescents. You know, once you analyze the data, what do you plan to do with it? And what does your outreach look like into the community?
Wow, that's a phenomenal question because I don't think I've ever gotten that question. What do you do with it? You know, researchers always want to collect more data and do more studies, but I think with this particular study, it is so important to do like a look back. And for other studies, what we've done is when we finished a project, we really try hard to present that data back to the community who gave us the data or answered our questions. And I think that's a really good way to partner with communities. With this study, it's a little bit bigger, so it's harder to get all 500 people, you know, back together and say, this is what we found. But what I found is it may be really nice to talk to the providers that are at those clinics and say, look, this is what's happening with our patients. This is what they're saying. How can we best make sure our clinics are here to support them? Or how do we get more community resources to the table to support our patients? So I think those are ways that we could utilize the data if we're not able to give it back to everyone. But we've started to collect data and ask kids, hey, are you interested in participating in further research? Hey, are you interested in learning the results? So the kids that have said yes to that, once we're finished, we'll send them newsletters and say, look, thank you so much. This is what we found. You make science possible. Because I think, especially with our population, they're not always asked to participate in research. And they, you know, may have negative feelings about what research is and what it means to be a research participant. So I'm hoping all of those ways can kind of help get back to our communities.
Great. what is needed to scale your research further? I mean, obviously, any financial donations, I'm sure, are very, very important, but are there other areas of support that might help advance your work?
Absolutely. I think funding is always very helpful because with that, it's the dollars to pay participants, but it's also being able to get a lab team that can be dedicated and call them, and social workers that are there to help our kids that are going through adversity or trauma, or psychologists or whoever. So I think that is important. I think aside from that, it's getting really excited community partners. I mentioned ACHiP, which is focused on Lurie patients, but also thinking about how do we expand to the South Side? How do we expand to the West Side? We just started a partnership with Erie Health Clinic, and they've got some teen clinics on the West Side of Chicago. So we're excited about that. But how do we make partnerships? How can people extend their network to allow us to make connections with other, people maybe outside of Lurie, outside of Chicago? How do we think about building those research partnerships and leverage what we already have within this, small but mighty community?
Great. I think one of our board members, Steve, has a question. So Steve, maybe you can go off of mute and ask Dr. Heard-Garris your question.
Yes, thank you. I see this area as phenomenally important, but I also see this area getting hit with a perfect storm. 14 million people are on the edge of eviction in the country. States, cities have dried up revenue, so they don't have any resources going forward. The amount of resources to kids is going to be next to nil going forward. I mean, you can even look at our own hospitals, revenue, which we all know about. The amount of kids that you're going to see going forward with issues is going to skyrocket. What is going to happen, or what are we planning to do as far as a full-scale rollout type of thing?
I think your question is one that we have been worried about with respect to not necessarily my research lab or the scientific community, but just as a country and as society, like kids that are already, that were already kind of hanging on, or families that were just barely making ends meet, how, are now even hit even harder with housing insecurity and also food insecurity. I know personally in my practice, we have seen there have been more patients that are requesting connection with food pantries or connection with help with housing and what that looks like. So I'm proud to be able to work for a clinic and an institution that really has already been thinking about that way before the pandemic started, and how we can connect families and patients with those resources. I think, as a society, and when we think about where our money goes, who we value, as you kind of stated, like kids don't vote. So sometimes it's hard to get the dollars towards schools and funding where, kids can actually really thrive. And so I think, we've got a transition of our government. We'll see how this new administration will navigate that storm. I guess I'm hopeful that there are a lot of people, including people within our institution, within Lurie, that know about this problem and have done a lot to try to get ahead of it. Like I said, in my clinic with the food pantry that already existed, but there's been many other kind of interventions as well. Do people need diapers? Do people need formula? Which were questions we weren't asking a year ago. I mean, people would bring that up to us, but we're asking everyone, no matter who you are, where you come from, what you look like, do you need help? Are you impacted? Because that's the way we can do that and within this scale. But, scaling up, I think, is going to really require kind of a multi-sector approach. Government, business, nonprofit, all of us really working together to help kids.
So I have another one here for you. How can the various stakeholders, like other pediatricians, other health professionals, how can they contribute to your work? What can they do? I mean, you mentioned that you're going to communicate, the results of your data back to them. but how can maybe they help in the inception and then help perhaps on an ongoing basis as well?
Oh, thank you. I love pediatricians, obviously. I became a pediatrician, but I really like pediatricians because they have hearts of gold and always want to help when they're doing 100 other things. So I appreciate the question. I think for me, one of the things that has been hard but good about this year has been that there has been such a focus on adversity, and there has been such a focus on kids and people that are kind of on the margins. And why that's been good is because people like me and others have been doing that work for so long and have been saying, hey, pay attention to this, without like a lot of attention. But I think now people are really, really understanding this is an important issue, and this doesn't only affect our kid or our grandkid, but our future grandkids and future kids. And so I think what's been great is pediatricians are paying attention too, and they're saying, okay, well, I didn't ask before, has your parent been incarcerated? I didn't ask before, are you having difficulty, keeping your lights on? But I'm going to ask now. And so I think that in and of itself, like getting pediatricians to understand that, beyond the medication and beyond, the things that we can do in clinic, there are real things, social adversities and social circumstances that impact health. And we can't help children without asking. So I think specifically getting pediatricians to partner with researchers that are asking the questions and that can study and understand how to best support our patients and our families. So getting involved and partnering, if there are pediatricians that have clinics that I'm not privy to, I'd love to think about partnerships with them. Great,
wonderful answer. Devaney has a question, another one of our board members. So if you would go ahead, please,
Sure.
Devaney.
Thank you so much for the presentation. It was really insightful. It is definitely a multi-layered kind of problem and situation. I was just curious if with those biomarkers, are you going to be looking at cortisol? I know you mentioned stress, but I was just curious in cortisol levels in particular within the blood samples, if you're able to kind of tease that out a little bit to have some type of correlation maybe with the different levels of ACEs or ACEs that are present, if you could draw some correlations between that with the inflammation and how that affects obesity. And then also, was there ever any consideration for like a participatory action research arm to this, maybe in like a second phase to get the kids that are, the 500 kids that are participating now to do something in the next phase potentially with that?
Gosh, such great questions. So your first question about cortisol. So it's a great question that we have struggled with back and forth. And one of the reasons why is that cortisol can be super finicky. You have to collect cortisol at the exact right time. So generally like first thing in the morning, and then there's another, it has like 2 peaks. And so we are only going to see the teens one time. And so to have one kind of sample cortisol number is not going to really tell us the pattern. So we made a decision to not do cortisol this time, but hopefully in another study, we can collect it via saliva, so spit samples, or hair, which people may not be willing to give hair samples, but in a subsequent study. But one of the things we're going to do is when we get the blood, we're going to freeze it, because my hope is that there are techniques and stuff that aren't even developed yet that may be able to allow us to get a better picture of what, how stress impacts health. And one of the things I'm really excited about, don't have a ton of funding to do right now, but like looking at epigenetics and how our genes actually respond and change to stress. How they get turned on, turned off, or dimmed because of stress exposure. And so one of the things I'd like to do in thinking about stress and thinking about response to stress is do that later on. I think your second question about this participatory arm, one of my favorite things is to work with youth and how to empower them, because as a teenager and as a person who actually was lucky enough to be able to go to college, I never thought I would be a researcher. I was like, oh, research, yuck. Like, they're not asking the questions that I care about. They're not studying the problems that are really salient to me. And so I wish I would have had a research experience that involved me. And so that's one of the reasons why I really like working with youth, to expose them to research. But as far as an arm, we are hoping in subsequent studies to be able to create like a teen advisory board, where we have teams that helped us to kind of come to questions together and actually help us work on the research, so that they're getting exposed earlier, creating a pipeline, but also we're asking questions that teens also want to know and have the answers to. Because I can come up with the questions all day, but if teens don't think it's important, it becomes really hard to recruit and really hard to engage them in the work. So hopefully down the line, we can create a teen action board, a teen kind of advisory board, and then also get teens to participate in the actual data collection and creating a study and teaching them those skills as well. I hope that answered your question.
We have another one. Wondering, and this is from Christy, our board chair, is there a consortium or a multi-city institution model that can help advance your study across more communities and more kids? You know, we don't, from what you've shared with us, we don't have a perspective on how broad reaching this might be and what Lurie's role could perhaps be with it.
Wow. So there is, if I don't know if folks are familiar with Dr. Nadine Burke-Harris, but she is a pediatrician that is now, I think, Surgeon General of California. So one of the things that she has really done is help to put ACEs on the map and try to bring pediatricians and researchers together. So there is a collective, this name is escaping me now, but I'm a part of, that tries to link people together. But I haven't been as successful in being able to navigate, okay, this practice in Oklahoma would like to engage in this work and would like to partner with people, and making those connections that are a little further out. The local Chicago connections are pretty strong. There's a lot of ACE work happening right here in Chicago and in Illinois, which is exciting. But outside, I've had trouble kind of trying to figure out who are those partners, who can those partners be. I think Dr. Burke-Harris has started, she's laid the framework, but I think we need to continue to build the infrastructure and create those partnerships to make it easier. So they do exist. I think they still are a work in progress, to answer the question.
I would just build on that. As I have received kind of more information about your work, I think about your work like I think about cancer research and the Children's Oncology Group, right? Which is this multi-institution model that's tackling this enormous problem. That model to me is as relevant for this research study as it is for oncology. And, you know, ching ching for you if you can figure out how to make that happen, because what's the problem in Philadelphia is the problem in Chicago, is the problem in Atlanta. It is agnostic to your city. It is in all of our cities. And if we could find a way to cascade the focus, so Atlanta's learning about this and Chicago is learning about that and Philadelphia is learning about this other thing, and it rolls together, that to me is powerful impact quicker. Right?
Oh my gosh, yes, 100%.
Yeah, exciting. All right.
It's like breaking down those like little silos that are kind of happening in other areas and like really putting that work together to create some powerful impact and scientific discovery. It's really important. Thank you for that.
So clearly no shortage of things for you to work on.
How many hours are in a day? No, that's great.
So any other questions from anybody on the line, board members or our guests? Please go ahead if you have one. All right. I will hand it back to you then, Christy, to close us out here. I think you're on mute.
I can just say, if I take myself off mute, that this session and all of the sessions that have preceded this this year would not have been possible without our education champions. And we are grateful to have So many companies and individuals prioritize education and the stewardship exposure that we can provide to people through this platform. So I just express my gratitude to all of those donors. I also join Kathy and our entire board in thanking you, Dr. Heard-Garris, for taking the time to share this important work along with our partners at Lurie Children's and at the Lurie Children's Foundation. Thank everyone who has joined us over the course of this past hour. I hope that you found this session informative and actionable in many ways. Or as I mentioned in the chat, a recorded version of this session will be made available to all of us to share with our networks. I would encourage you to share that further. And again, to leave you with just one thought, that our board is a volunteer board, a board that has both an education and a fundraising focus. We are the longest standing partner supporting research at Lurie Children's Hospital. And so if you found our content today interesting, and if you'd like to learn more about our board, we would encourage you to reach out. Thank you once again, everyone, for joining us today. And for those of us who are on the board, please stay in the Zoom as we will begin our board meeting momentarily. Thank you again, Dr. Heard-Garris.
Thank you, Dr. Heard.
Thank you for having me. Have a good meeting.
Pleasure. Thank you.